So, dear colleagues, we go on in the program, and I just learned that the live case is ready, so they will now present it. And I'm curious what the Holy Anna is offering.
Hello, can you hear me? Hello, good morning.
Yes, we are ready here, and we are waiting to learn more about the live case. Can you hear us?
Good morning, everyone, from University Hospital St. Anna. We are live with the first case, and it's a 62 years old female with liver cirrhosis, and she has HCC, which means hepatocellular carcinoma, which was diagnosed in August last year. And now, last month, she had progression of the hepatocellular carcinoma, and she is now scheduled for transarterial chemoembolization TACE procedure. Now we did some reconstructions of the CT scan, and you can clearly see the celiac trunk, the proper hepatic artery, and the mesenteric artery. We are now selectively engaged. We will now selectively engage the celiac trunk. As you can see, it's a very steep angle for femoral axis, and you see that we chose the radial axis in this case. Now you can see the hepatocellular carcinoma on the right with the red circle, and then that's the left hepatic artery, the middle, and the right. And you can see that the hepatocellular carcinoma is in the fourth A segment of the liver, and we will selectively engage the middle hepatic artery. We chose the left radial for the celiac trunk anatomy. We chose multi-purpose 5 French, and we put 2.4 prograde microcatheter in the multi-purpose catheter, and we will now try to be selective, selective in the middle hepatic artery. And now to Professor Velchev.
Okay, Professor Matthias, I'm glad that we have an intervention radiologist moderating us. So I will walk you slowly what we do up till now. So first of all, we selected left radial but not right, because the length of the catheter when you're working with a 100 centimeters catheter is better to work from the left, because you spare some few centimeters. And first step is to go selectively in the trunk. So I hope that you see the angio. Now we are selectively, having the picture of the whole anatomy. And you may notice that in this situation we have three branches coming out from the common hepatic, which is left, right, and in this situation we have a so-called middle hepatic, which is supplying the fourth segment, and that's where we want to go. And after we are selectively, we go with a 2.4 French microcatheter, and now we are inside the middle hepatic artery, and you may appreciate a specific blush of the tumor. Can you see it?
Yes, you can see it very well. It reaches up to the diaphragm.
Yes.
Yes, it's 2.4. So now we will try to go a little bit further deep selectively, because we see there is a one branch which is not supplying the tumor. So we'll try to go a little bit more selectively to go directly into the tumor feeding vessel, and then we'll start to embolize it. Dinko?
Коя водата?
Yeah.
Има различие или не?
So it's 2-point French Terumo Pro grade catheter. It comes with very hydrophilic type, which is a bit more explosive than a standard French 40-inch wire from coronary procedures. So we are going now with the viral. We try to go a little bit deeper. It's a 6 centimeters tumor, so it's not completely, it's not a small tumor, it's a medium size. If we are not able to go absolutely selectively, we probably will accept this position. Okay.
Should we try with the coronary wire?
Now this wire is a little bit too stiff. To
One
overcome
hint from the radiologist, because I have a talk
Sorry?
after lunch time about radiation protection. So I would use the shutters a little bit more from the side. That saves radiation, scattered radiation.
Okay. I didn't mention that we are using a specific calibrated spheres from Terumo. It's 200 microns. Usually for a tumor of this size, we think with 200 microns. And it is loaded with idarubicin. Idarubicin is a relatively new drug, and there are some data that compare to the doxorubicin, it have more favorable response of the tumor, and probably it's less toxic. So I'll try to go in there. So 2.4 is the catheter that we selected here. And now before we embolize, we are going to inject. We are using a small syringe and half contrast and water. May I have amplification, please? Okay. Не дишайте за момент, не дишайте. Okay, now I think I'm quite selectively inside the feeding vessel.
Yes, very nice.
And we will start to inject very slowly the spheres now. We loaded 1 cc. We diluted it with half contrast and water. It's very important for the injection to be slow. So we don't want to block a feeding vessel very quick. In some places they would even do any with the injector, but we are
You mentioned a very important point. When you embolize, do it slowly, so that the particles go in the periphery and will not block central parts of the artery.
Mm-hmm. So then we will have a control CT, and if we are able to downgrade the size of the tumor, Maybe we're going to discuss with the surgeons, is it resectable or not? But 6-something centimeters, even a solitary tumor for now, it's non-resectable. So we don't have an option from surgery here.
Yes, especially when the patient suffers from cirrhosis, because then the liver function is already a little bit
Absolutely.
reduced, and so resection is then a problem.
Има ли контраст вътре?
Мога да сложа още?
Да, дай, цялата. So what we want to see whether we have a backflow or not, but for time being, it's diluted contrast. I'm not sure that you see it, but we don't have a backflow, and we keep pushing very slowly. When we have a solitary tumor like this situation, most of the time we will finish with the gel-spon. Even there is some discussion if you're using a microsphere, should you go for gel-spon or not. But in this situation, we want ischemia to be full, and we are really hoping to be able to downgrade this. Just I will do a small puff. Не дишайте до момент, не дишайте. Okay, we have some effect, but still we have plenty of vessel, and we don't see a portal vessel yet. Maybe a small one. So we will keep slowly pushing some more spheres. This is the boring part of the procedure. We're already in there. So we need the patience for slow embolization. Very rarely, but in our practice, we have a few cases when the tumor is very proximal to the capsula, and we have an invasion of the capsule and bleeding in the peritoneum. And in this situation, it can be life-saving to block it quickly, because otherwise you will have a hemoperitoneum, which is not nice. Now we have a renaissance of this procedure, and we have a few new types of particles coming, like a bioresorbable. It is still not sure whether she will be using a permanent like we use now, or bioresorbable spheres. And of course, there are still quests for the best chemotherapeutics, because you know usually this is done with the doxorubicin, but doxorubicin, if you put it transvenously, is not very effective. So you need a very, very high local concentration if you want to have a real effect. Idarubicin is very promising. The Chinese guy reported we have 20% less relapse and better effect on the size of the tumor. So we're using idarubicin, and we hope for the best. Приготвите ги го спомня всеки случай. I want to show to the public how to prepare a gel upon slur, because it's something you have in every cath lab. And now our nurses and Dr. Kamburov will show you how to prepare a gel upon swirl.
10 кубикова шприца.
You can call it slur or jelly.
Там 10 кубикова шприца.
Our microcatheter migrated a little bit down, but I think that we already have most of our embolization agent inside the tumor. I will check it now. Поемете дълбоко въздух и не дишайте. Oh. Okay, we need to go back because we lost the position. Sometimes when the patient is taking a deep breath, you may inadvertently pull the microcatheter back, like in this case. That we want to be selective, so we will go back.
That looks good now.
Yeah, so it is not always easy to take the final turn.
Да отида да държа катетъра.
We'll give it one more try. I'm keeping my eye on my catheter, which is inside the trunk, so I don't want to lose a position here. Динко, би ли държал? Добре.
Леко ще отдръпна още обаче.
Така, слухай го това. Okay, we're there. Да, още партикули. I think it's very unusual interventional cardiologists to do tumor embolizations. Maybe it's something very specific for our situation here in Bulgaria, when interventional radiology is relatively underdeveloped. But there is a demand and this procedure needs to be done.
Само че може би трябва да го покажем на камерата как става.
Okay, can you look now the camera? Би ли го показала? You first put a gel spot inside water, you wait a bit, and then you start to shake it between the two syringes. And usually there is now a slowing of the contrast in the feeding vessel, so we're almost ready. Okay, so final check.
Адриана, не дишайте. Do we need gel spawn?
Yeah,
Now, what do you think?
I think most of the feeding microvessels are already gone, and we have some backflow, but we'll put some gel spawn, if you don't mind, just to block this vessel, because we are very selectively, and we wouldn't harm. Yeah, that's okay. There is no harm for the normal parenchyma. It goes relatively easy, even with 2.4 microcatheter. Of course, bigger microcatheter would be easy. I think we block it, but I'll push some more. water to be sure that we don't have gel sponge stuck inside the microcatheter. And then now we're checking the results. Не дишай, ако обичаш, не дишай. Okay, I think we
Yes,
finished.
it's very well blocked. I think that you have done a great job.
So I think it's relatively simple philosophy. Now we are taking out everything. You are taking out, while aspirating the microcatheters, we take out the multi-purpose catheter, and then the sheet from the radial is taken out on the table. The patient can be ambulated right now, and we hope that we will not have post-embolization syndrome. We will have some degree, but usually it's not very severe, so most of the time the patient goes home next day.
Yes, perhaps you should have a CT control of the abdomen the next day.
Yeah. Probably
see-
we should do some CT, but we'll wait a few weeks and then we'll do it, not tomorrow.
Okay, so
And,
congratulations.
obviously we'll check.
Perhaps you hear the clapping of the hands here in the room. Yes.
Okay, thank you so much. See you soon, and bye from Santa Ana for now.
Yes. Thank you so much.